at a young age, if your child has adenoids and tonsil issues, I really recommend trying to figure out a way, either holistically through like allergy tests and everything, to get those so they can breathe well at night. One of the courses I went to said that sometimes kids will suck their thumb. I think it was the orofacial myofunctional course, because they want to open their airway up. I want to talk to a second about orofacial myofunctional therapy and orofacial myofunctional disorders. Welcome to the Authentic SLP, a podcast for parents and speech therapists when you feel stuck and not sure where to go with your child. I'm here just to be a sounding board and support, and also connect you with other providers that can help you specifically for your child and your situation. So today I want to talk about just something that I see so often, that it's such an easy fix. And if you do not fix it early, can cause some major issues. This is going to be for speech therapists and parents, because I think as speech therapists, we need to make sure that we are being more vocal about it when we see it. Okay. So in some courses that I've taken and just what I'm seeing right now in the speech therapy world. So orofacial myofunctional therapy and oral motor and tongue ties and all of that we're going to discuss today. And I think it's super important, and I'm excited to share what I've learned and what I've noticed and what I've known, and things that aren't being said that are very clear to us as speech therapists, and the trainings that we've taken have become more clear. So right off the bat, I'm going to talk about babies and tongue ties. So when you have an infant who is not nursing well, the first thing that the nurse is going to do is check for a tongue tie, or a lactation consultant. And this is super important, because if they do have a tongue tie and they can't latch, they're not getting the hydration and nutrition they need to grow. So that's huge. And the doctors are going to be, of course, if it's a simple fix and they can just do a tongue tie release or a lip tie or a buccal tie, and that baby can nurse right away, or they can take a bottle, and then that's good, right? The problem is that I don't believe that's usually all it is. I think sometimes that's what it is, but for, I would say 70% of the cases, those kids end up still having some kind of issue. Either they grow up to be more picky eaters, they have feeding issues, they have speech issues, they have sleep issues, because that's usually not only the reason. Okay, so excuse me. So for speech therapists, I'm going to tell you a little bit about some of the courses that I've taken. And the one course I highly recommend that everybody should take is Beckman. So Deborah Beckman is amazing, and I think she was before her time, and I will talk about that more. She's still teaching the course. I know she's trying to find someone else to take over eventually, but she's teaching the course for the Beckman oral motor. I think, like I said, she was ahead of her time. So we're now starting to realize as a field that oral motor may have something to do with some of the speech disorders. I'm not saying it's the reason for every speech disorder, but it's something that should be ruled out, and often is not. Beckman does a lot of oral motor stretches and strengthening. I think that babies sometimes need more of just oral motor skills, because how you were in your mom's womb, like maybe your neck was in a weird place and you're developing some torticollis, or like something pulling here. So your tongue may seem down, but this really that you're developing some kind of torticollis from where you were in your mother's womb. So you have some tightening here. There's just a lot more going on at the base of the tongue right here. Like, do this. Did your tongue move? Like, you feel a little strength in your tongue? Like, pull your neck this way. Like, you feel that pull on the base of your tongue. So the base of your tongue doesn't always mean it's tied. It just means that maybe there's some things that you need to do, like working with, I know people have mixed feeling chiropractors, but I think there might be a good idea for some babies that have some issues, or just like body workers and massage therapists and stuff like that. Like, maybe that's a good choice instead of just cutting the frenulum. So the frenulum is the piece of skin underneath your tongue. So you'll have one. And there's a frenulum here, so a lip tie here. And then there's also a buccal ties, which is in your cheek. So I'm going to call them all ties, but doesn't always mean that they're ties. I'm just going to use the word tie, but I'm not going to say there's a tie. So what happens is, if you have tight here, like if I'm really tight here, like this muscle is tight, right? So it's pulling down on my tongue. or any muscles, if I take a piece of fabric, I'm just going to grab a piece of fabric here. Okay, here's a blanket. Here's a blanket, right? If I have like a seam in a blanket, well, okay. So here is it's the tie or the connection, the frenulum between my cheek. If the skin around it's nice and relaxed, you don't really see the tie. But if it's really tight, I can't even do this. It's gonna make that tie look, if the tie is really tight, it's gonna make the skin around it's gonna the tissue around it really tight. It's gonna make that frenulum look tighter, but it doesn't always mean that the frenulum is tight. That's just the skin. If there's other places around it that are pulling it, it's gonna make the frenulum look tighter. We all have frenulums in our cheeks. It doesn't actually mean they're ties, though. Does that make sense? So all these babies, what's happening is if that wasn't the root of the problem, if it wasn't actually tied, they're still having trouble with eating and sleeping and all that stuff because that wasn't the reason. So another reason, so that is a thing, tongue ties. And I know, like, I was a tongue tie like guru 3 years ago, and I even got my tongue tie released. And I look back, I don't think I had a tongue tie at all. I took Beckman and I realized that I still have issues. And I think it's because of other things like I've got a retracted tongue, but I'm not going to go into it. Basically, I don't think that babies all need their tongue ties released, and cheek ties and lip ties. It's becoming too much. And then, like, I have had families that have come in that have had 3 to 4 releases. Like, that's a lot to cut that for a baby or a child or anybody. If it didn't work after the first time, my guess is that it probably wasn't really tied. But that's just my opinion, and people aren't going to agree with me, and that's okay because I love hearing people with different opinions. Like I said, I was 100% in the tongue tie thing, and then I'm like, okay, I've actually seen improvements with kids not doing tongue tie releases and doing more oral motor work. Now, if you've been a client of mine and I had to get a tongue tie release, I meant it. Your child probably did have a tongue tie, but I just took the Beckman about 1.5 to 2 years ago, and now I'm really realizing that a lot of those things were missed. I highly recommend, if you're a speech therapist, to go to Beckman. And if you're a parent, I would ask your speech therapist, especially if you're an infant, find a speech therapist who's been trained in Beckman, like from her course, not just like a colleague of them and they have the book, like an actual person that's been to the course and knows it well. Because again, you can go to every course, but you don't have to pay attention. So make sure they know it well. It's something they're comfortable with. If you have babies not having trouble nursing, I also think it's good for all kids if they get lots of reasons. So that is the reason. If you don't fix those tongue ties, if they do have a tongue tie at a young age, it does cause feeding issues. It does cause speech issues. So yeah. Because basically what it does is it makes your tongue rest on the bottom of your mouth. And when your tongue is low and down, the top of your mouth, which is called your palate, does this. Okay, this is my palate at the top. My tongue comes up here where it's supposed to be. My palate stays nice and wide up here, right? You know, sort of palate expanders, right? So your palate here, you want this to be nice and wide, and this is how it shapes your face. Your tongue rests down. What happens to your palate? It becomes narrow. Mine is narrow. I'll show you. I'm very narrow. It looks high, but I wouldn't use the word high. I learned that from Beckman because it's not going into my nasal bridge, but it's high. The vault is pretty high because of it being so narrow. I should have had a palate expander. Okay. But I didn't. My orthodontist should definitely have recommended it, and I'm sad about that. And that's why you'll notice, like, kids, when they're pulling a lot of teeth, like, don't do that. Go see a orofacial myofunctional therapist before you do that. So that's kind of like from the start, from the babies. Other reasons, well, after 12 months, I mentioned before, you shouldn't have pacifier or bottles. And that is a huge thing. I get kids, they'll go to a big hospital and get a diagnosis of apraxia too. And I say, okay, but they're talking with a pacifier in their mouth, right? Yeah. When you talk with a pacifier in your mouth, their tongue is down. It's not hard, but I don't I didn't talk like that all the time. And you don't want that because then you're learning the wrong way to talk. So pacifiers or bottles all the time is not good. It's also going to promote that high narrow palate and the tongue down, and your jaw is going to become weak. And your lips and your tongue your cheeks are going to get tight, and your lips and this area is going to get either tight and weak, and this is all going to be out of balance. And that's why the oral motor therapy is important. So bottles and pacifiers after 12 months, like, do not do that. Do everything you can to not have to do that. Same with, and this is the hard part, when it comes to sucking thumbs. Really try to stop it. Now, this is interesting. So what I learned from a course, so I took autumn Henning, I think, is the TOTS tongue tie course. That's kind of the first course that kind of started me on this oral motor journey. And then I took Keisha Nolan's Mastering myofunctional course, which is fantastic. Both great. Highly recommend, but if I had to pick one out of the three, it would be Beckman. So adenoids and tonsils. Okay. So if you have large tonsils or adenoids, that's going to make you breathe through your mouth and your nose because your nose will be blocked. Okay. Especially those adenoids. So even at a young age, you can get those either removed or talking to an ENT, or if you're more into holistic doctors, sometimes it's because of a food allergy that is causing the inflammation. And if you want to go through more holistic allergy-wise, instead of just taking your adenoids out, I know that is an option. Like I said, I don't judge parents for anything. Well, for some things, but I'm happy with going more holistic or more medical. It's kind of where you guys feel comfortable. I mean, it's very easy just to go to the medical doctor and say, take out their adenoids and tonsils if they need them out. By the way, if they cannot see adenoids by just looking at them, you have to get an x-ray. So if you go to an ENT or a doctor and they say their adenoids are fine, they don't know. Because then unless they did an x-ray, they don't know. So make sure that you get that done. And you can ask your doctor, your pediatrician, just to get an x-ray of the adenoids before you send them to ENT, because that way you can rule that out. So all of adenoids and tonsils is the way that your tongue would be down, your jaw would be open, and it would be changing the way your face looks. Like, it's all bad. And guys, if you're adenoids and tonsils and you're taking a pacifier, a bottle, all those things that your tongue is down, your airway is compromised. And if your airway is compromised at night, that's like more like a sleep apnea. Your kids aren't getting good sleep. They're wetting the bed, having behavior issues in school. So if you don't get this done from a young age, and this is when your child's brain is developing and you're not getting good airway when they sleep in good sleep, that's not good. That's why this is so important, and it's such an easy thing to fix, but people aren't doing it. And that's kind of like why I said I wanted to do this podcast, because it's so important. And I've seen the effects. I've seen kids get their adenoids out and all of a sudden they're eating foods and they're breathing and sleeping through the night, and they're not wetting the bed, and their behavior improves because they can finally sleep good. Another thing you can do, if you're not sure if you want to take your children's adenoids out, is get a sleep study to see, is it affecting their sleep? If you're not sure, like, I'm not sure, I don't want my kid to go to the surgery, we'll see how many times they don't breathe at nighttime, and that might help you make a decision. So yeah, pacifier bottle, adenoids, tonsils, tongue ties, all reasons why your tongue would be low. Sometimes kids just have low tone. Again, that could be genetic reasons, that could be something, or high tone issues, that could be cerebral palsy or Down syndrome or genetic disorders. There's other reasons why your tongue would be open, your mouth would be open. All those things. That is a little bit different, not as easy to fix. We need more medical professionals in that. So I want to talk to a second about orofacial myofunctional therapy and orofacial myofunctional disorders. Okay, so at a young age, if your child has adenoids and tonsil issues, I really recommend trying to figure out a way, either holistically through like allergy tests and everything, to get those so they can breathe well at night. One of the courses I went to said that sometimes kids will suck their thumb, I think it was the orofacial myofunctional course, because they want to open their airway up. So if they have enlarged adenoids, they'll actually suck their thumb to open up their airway so they can breathe. So sometimes just by taking care of that, you'll get, it's easier to have them stop sucking their thumb or fingers. Orofacial myofunctional therapy is usually good for kids like over 4 who can follow directions. But I'm telling you, you won't need orofacial myofunctional therapy. And if you can take care of these issues at a younger age, and Beckman oral motor can do that, because you don't have to follow directions for Beckman oral motor. And orofacial myofunctional therapy does not work for a lot of our kids because they're not ready to follow directions. I just want to talk to you a little bit about orofacial myofunctional therapy and speech therapy in this world, and how it's changed, and why I think Deborah Beckman got it right. And she was ahead of her time. Well, like I told you, I took the TOTS course, and then I took orofacial myofunctional, and then I took Deborah Beckman. And she has 2 courses, the regular Beckman course and then a deep tissue course. I highly recommend both. And I think the deep tissue course is, like, honestly, It takes you to the next level, especially like for babies, and highly, highly, highly recommend. So, orofacial myofunctional therapy started in the early 1900s by dentists, and it was mainly for like orthodontic reasons and for braces. And what is the main goal of orofacial and for airway? Open up their airway so people can breathe better, and also helps teeth. So if your tongue is resting in the right place, on your upper palate, your palate is wide, your teeth are going to grow in better. If this is constantly tight, you might have like your teeth that are going to start pointing inwards. I don't know. I'm not a dentist. I will have dentists on here and they can explain more. But basically, orofacial myofunctional therapy was not a speech therapy thing and didn't really become a speech therapy thing till like this 80s, I researched. So in the 80s, what happened is these people with orofacial myofunctional therapy disorders, which is like airway disorders related to tongues and breathing, they were getting, if they had a lisp, the lisps were getting better. If they were picky eaters, their eating got better. They weren't as picky. Like they were chewing and swallowing foods better. Their digesting got better. All this stuff happened as a result of orofacial myofunctional therapy. So speech therapists were like, hey, this is helping people's speech. Like we should get on this. I think that's how it went. I actually don't know. So now orofacial myofunctional therapy has become such a thing. And so dental hygienists can do this, or speech therapists, speech language pathologists, feeding therapists. We're the same thing. But anyways, so if dental hygienists can do this, this is not a speech and feeding thing. So it's an airway thing. It's for airway and dental. Now, it does help. But what I think what's happened is, since the orofacial myofunctional therapy thing has gone off, tongue placement, cheeks, like, working on all of that for speech and feeding, but really it's for airway and orthodontics was how it was created. It just kind of proves that oral motor is needed for speech. A lot of our kids do need oral motor therapy, and that's where Deborah Beckman got it right, ahead of her time, because it's true. So if you want to see an orofacial myofunctional therapist, great. Like it's good for your child's airway, do it. We do it at our clinic at Bayside. I highly recommend it. But again, if you didn't take care of those earlier things, it's not going to work. For an example, for me, and I keep learning, but I was in speech therapy, if you don't know this yet, for R's and S's and lists. In fact, I was like not intelligible at all in kindergarten and first grade. I looked at my IPs. No one could understand me. And so I look back and I honestly think, are you ready for this? I think it was my core. I think I had a weak core, which caused this is all uneven, which caused my tongue to retract. I might have had reflux. Reflux can cause tongues to retract. And there's a lot of things like oral motor and structure wise that it can affect. So I realized that my tongue was low for some reason, and now I have a narrow palate. And because I have a narrow palate, I cannot make this wider now. I would have to have jaw surgery to make this wider. And I know there's some things dentally we can do dentally. And I know I've talked to a dentist about it. So I'm interested to hear more about what they say we can do as adults that doesn't involve surgery, because I don't want to crack my jaw open just so my tongue can fit better in the roof of my mouth and I can breathe better at night, because that's what happens. So if you don't fix it before the age of 15, what happens is you can't correct it without surgery. So that's why getting that tongue placement up there at a young age is so important, as that palate expands, and that's what you're going to have for their adult just development. And so it's going to stay there. And if you don't fix it, we'll get 38, 40-year-olds, 50-year-olds who are like, how can you fix this? But their palate's so narrow, their tongue won't even fit there, so I can't even do orofacial myofunctional therapy on them without surgery. And so then they're stuck with like needing to get sleep apnea machines and everything. So getting this done at a young age is so critical. And also like pacifiers and bottles, like using those for a long time, it's going to do, or sucking your thumb, it's going to do the same thing. So I think if I would have had more oral motor therapy, I wouldn't have been in speech therapy till I was I think I was probably in there for R's till I was in like 5th grade, and then a little bit of lisp. And I still do, because my jaw is crooked. And my jaw is crooked. Why? Probably because everything is off and my core is weak. And then there's just so much going into it that's not just speech and phonological, which is a speech term. So this is such an easy thing that you guys can do. You can look at your child's palate. If you notice that it looks very narrow and their tongue is laying down, like that's enough to go see an ENT or a holistic doctor or allergist. Why is my child's tongue low? If their tongue is low and they're breathing through their mouth, it is not good for them. I mean, think about it. When you get a cold and you can't breathe through your nose and you're only breathing your mouth, how do you sleep at night? It's not good sleep. Your lips are dry. You don't feel like you got a good rest. And if your kids feel like that all the time because they're breathing through their mouth, it's a problem. It's a problem. We want good nasal breathing. So it's a great thing, but that's why I'm like, orofacial myofunctional therapy is great, but I think it also could be addressed with just like oral motor therapy, because orofacial myofunctional therapy is great, but it's not like the end all be all. And sometimes it's a lot more complicated than our kids actually need for speech and feeding. It makes us be like, there's a lot of programs that have so many, like 28 different extras and different, it's so over complicated. And in fact, I did find a book that was published in 1993 that I highly recommend. And I'll share with speech therapists maybe in my next session as a gift, because I will save you lots of money, because someone got it right in 1993 and they made this book, and it's on Super Duper, that is better than any orofacial myofunctional therapy program I can find, and it's easier and it's done in 12 weeks. If you have a speech therapist that you've been, your child's been in speech therapy for lisps or R's over 6 months, you probably need to ask your speech therapist, like, can we do oral motor? Do you know anything about orofacial myofunctional therapy? If it's not orofacial myofunctional, that's fine. Is it oral motor? Do you know about Beckman? Do you know about tonsils? Because sometimes if they're not making progress for articulation, especially in 6 months, but they're not making significant progress with a child, I'd say over 4, you still can't understand them, I would definitely want to make sure that you've done a good oral motor evaluation on them. So if you don't fix their tongue position at a young age, you're setting them up with sleep issues, attention issues, everything for the rest of their lives. Braces, like, this can save you money in braces if we can get this fixed at the beginning. A speech therapist, like, where should you put your money in? I would say Beckman, and along with phonological approaches. I'm not saying that kids aren't phonological and you can't do both, but if you just treat phonological and they do have oral motor disorders, then they're going to probably have sleep and airway issues, and because you're not really getting to the root of the issue, you're just kind of fixing the surface. And I'm not saying that everybody needs it, but it needs to be ruled out. That's all. It's just like phonological disorders, it needs to be ruled out or done together, because a lot of kids have phonological where they can't hear it right, or then they also have oral motor, so it can be both. So yeah, I'm excited about our next guest. I don't know who it's going to be, but I'm going to make sure that we have someone on here for next time. I hope this is helpful. I think it's a really important podcast to share with everybody you know who's going to have a baby. Like, every parent needs to hear this before they have a child or a friend of a friend, because if they're going to have any feeding issues at all, or any speech or sleeping, like if the kid's not sleeping well, it might be because they're mouth breathing, and mouth breathing is not okay. Like, it really does show a sign of something else going on. So I'm also free for consults if you have questions about where to go, which providers to pick, or if your provider that you have currently is being able to rule out these things, or they just haven't even addressed it, which is so common. They aren't even addressing these issues at all. They're having them do what they learned in grad school, which is basically nothing. And even if the child did have a problem with that, they wouldn't know what to do. And I'm not putting them down. You just don't know what you don't know. I didn't know either. So, all right, have a great day. And if you want to book that consult, you can have a Calendly in a link tree now. So you can book an appointment in Calendly, and I can consult you on like what you should do for your child and make sure that you're on the right track, kind of a sounding board and a person who can connect you to other providers who would be a good fit, and let you know too if your child actually does need these types of services or not, through just talking to you. So have a great day. Thanks for joining us.